Thank you for listening. This is Dr. Cheryl McDonald of Health Psychology, and today we'll be talking about life with chronic pain. Chronic pain is a debilitating condition affecting an estimated 1.5 million people worldwide. Along with suffering merciless or recurrent pain, victims may encounter depression, anxiety, and sleep disorders. Untreated, chronic pain can disturb family life and hinder everyday functioning. Nearly all chronic pain, nevertheless, can be greatly relieved with proper management, although patients with chronic pain usually undergo many different treatment options before finding an approach that provides relief. The American Academy of Pain Medicine affirms that approximately 35% of Americans have complaints of severe pain, and 50 million Americans are disabled partially or entirely due to this condition. Coping with pain is an extremely common symptom that causes people to make multiple appointments with their physician, and this problem is better managed by using a multidisciplinary approach, requiring close integration with various healthcare providers. Pain has biological, psychological, and sociological components. A brief history of the study of pain. For as long as mankind has been aware of pain, the healthcare professionals have provided reasons for its presence and explored calming agents to numb or stop the unpleasant sensation. This section concentrates on the historical archives of how pain is perceived across culture and time. A person's judgment of pain varies and relates to determinants because circumstances, environments, and the individual's past history of experiencing pain. Archaeological data and petrified poppy seeds imply that Neanderthals may have practiced using the opium poppy over 30,000 years ago, possibly for pain relief. Paleontologists have discovered clay tablets recording back as distant as 5000 BC, explaining how to garden and apply the opiate flower to produce joy and ease pain. The Greek writer Homer in 800 BC wrote in the epic The Odyssey by describing men who drank opium and wine to relieve pain or forget their worries. Some older societies investigated analgesics and promoted the practice, while others saw the pain as being a vital, essential emotion. Practitioners of the 19th century thought that the pain levels were a diagnostic agent, hypothesizing that a greater amount of personally noted pain bonds to higher inner energy. Discomfort was a therapy in and of itself, and the forcing of pain on the sufferers was treatment to free the patient of sinister beliefs that were causing the unstable health status. Since modern findings of the neuron and how they send and translate signals covering emotions such as pain, several assumptions have been suggested as to the causes of pain and its purpose or intent. Indeed, within obviously defined societies, such as the ancient Greeks, there were opposing theories as to the pain's origins. Aristotle thought that the pain was caused by a sinister essence that pierced the body through damage or injury. Like Plato before him, Aristotle viewed pain and joy not as feelings, but as passions of the soul. Hippocrates concluded that the pain was an irregularity in the essential liquids, called humors. During this time, neither Aristotle nor Hippocrates wondered if the brain had any capacity to interconnect with pain processing, and associated the heart being the primary organ for the perceptions of pain. Avincula hypothesized that there were plenty of feeling sensations involving pain, touch, and excitement in the 11th century. In Europe, before the scientific Renaissance, pain was not adequately understood, and it was reasoned that pain lived outside of the body, being a discipline from God, and the prescription was prayer. Within the restricted society of the religious practicing Christians, more than one opinion emerged, such as, pain lives because it is a quiz or experiment to test an individual's endurance. In this instance, pain was a strike by God onto a person to reaffirm their belief, or in the case of Jesus, to give legitimacy and faith to a claim through misery. René Descartes, in his Treatise of Man, 1664, speculated that the body was more alike to a machine, and that pain was a change that moved along nerve filaments until the disturbance entered the brain. This assumption converted the understanding of pain from a spiritual, mystical encounter to a physical manufacturing sensation, suggesting that a remedy could be obtained by researching and locating pain areas within the body rather than seeking submissions to God. This assumption converted the understanding of pain from a spiritual, mystical encounter to a physical, manufacturing sensation, suggesting that a remedy could be obtained by researching and locating pain areas within the body rather than seeking submissions to God. This thought removed the center of pain awareness and attention from the heart to the brain. Descartes explained his argument by demonstrating a picture of a man's hand being hit by a mallet. In between the brain and the hand, Descartes delineated a hollow hose with a cord, originating at the hand and stopping at a signal found in the brain. The strike of the mallet would provoke a pain in the hand, which would attract the cord in the hand and produce the signal resided in the brain to respond, explaining that the brain had caught the painful information. Researchers started to seek physical therapies, such as cutting precise pain threads to block the painful signal from traveling to the brain. Long after the age of Descartes, in 1975, the International Association for the Study of Pain investigated a general agreement for the definition, concluding an offensive sensory and mental activity linked with real or possible tissue injury, or explained in terms of damage being the final definition. It is apparent from this definition that while they recognized that a pain is a physical sensation, the emotional disposition of a person, as well as the circumstances or conditions associated with the pain, also influences one's perception of the harmful experience. For example, if a person experiences a painful situation connected with current or previous injury, a disease, an accident, or a trauma, a reoccurrence of related physical pain will not just cause physical trauma, but also the emotional and subjective trauma connected to the first painful experience. Researchers have studied comparable injuries between two people. One person who identifies great emotional disturbance to the pain, and a person who does not identify emotional disturbance. The person who associates a high disturbance will have more extreme physical pain than the person who does not connect a high emotional response. Supplementary investigations have revealed that the existence of pain is molded by an excess of contextual situations involving vision. Researchers have observed that when a person sees the region of their body that is being aroused, this person will describe a diminished significance of recognized pain. For instance, one study applied heat stimulation on a person's hands. When advised to watch their hand when the heat provocation was administered, they experienced an analgesia result and recorded a greater heat discomfort threshold or less discomfort. Additionally, when the appearance of their hand was visually increased, the analgesic impact also rose, and vice versa. This study illustrated how the judgment of pain relies on visible information and was conducted by Mancini, Logo, Cammers, and Hager in 2011. The applications of MRIs to examine brain activity strengthens the bond between visual awareness and pain perception. It has been observed that the brain areas that communicate the perception of pain are the same areas that encode the extent of visual information. One distinct region, the magnitude-related insula of the insula cortex, operates to recognize the size of the visual stimulation and integrates the idea of that size across many sensory modes involving the judgment of discomfort. This section overlaps with the pain-specific insula, the piece of the insula that selectively prepares pain nerve cells, driving to the determination that there is an intercommunication and bond between the two areas. This interaction explains to the individual how much relevant pain they are feeling, pointing to the personal judgment of pain based on the visual provocation. Conditions that cause pain. The typical causes of chronic pain are inflammation or injury, influencing muscles, myalgia, nerves, neuropathy, and/or joints, arthritis. Pain symptoms associated to joint damage involve osteoarthritis, which is the most prevalent reason of persistent joint discomfort, and rheumatoid arthritis, which is when the body's own protective mechanisms attacks the joints. Pain associated to nerve damage involves diabetic neuropathy, appearing in painful feet, tic douloureux or trigeminal neuralgia, a disease that involves severe facial pain, post-hermetic neuralgia, the irritating pain that may accompany shingles, and post-amputation pain, which occurs following the removal of a limb. A distinct kind of pain is psychophysiological and does not relate to illness or damage that is currently known, requiring more investigations. Sufferers with this pain have genuine distress, but no cause of pain can be recognized, or the level of pain overshadows any known plausible condition. On account of the organs inside the body not possessing pain fibers, like the joints, skin, or muscles, organ injury may be indicated by chronic throbbing or aching discomfort that has the label visceral pain. Cancer of an organ, for instance, the bowel, kidney, or liver, inflammation or infection can cause visceral pain. The treatment of chronic pain in adults is an embarrassment to healthcare professionals, from inadequate preparation about any features of pain to a common view that people requiring opioids for chronic pain are guilty until proven innocent. Unfortunately for all concerned, even oncologists receive essentially no education in pain administration. Chronic pain is connected with various illnesses and disorders. People suffering from any of the following illnesses may experience some of the cognitive and emotional symptoms that are linked to chronic pain. These illnesses or conditions include arthritis, sciatica, back pain, fibromyalgia, clinical depression, migraines and headaches, irritable bowel syndrome, chronic fatigue syndrome, myofascial pain syndromes, complex regional pain syndromes. Chronic pain syndrome. Chronic pain syndrome, CPS, is a constellation of signs which usually do not respond well to the medical model of care, producing quite a challenge to people in the medical professions. CPS is a poorly defined illness because some researchers believe that a consistent pain lasting longer than 6 months, and others have used 3 months as a minimum standard for the diagnosis. Still, yet other researchers suggest that any pain which persists longer than the average healing time should be considered chronic pain. In general, chronic pain is defined as any pain that lasts more than 6 months versus acute pain, which is a pain that can last less than 30 days. Once again, any pain that lasts between a month and half a year is classified as subacute pain and is not considered to be a chronic condition. Chronic pain syndrome is a problem that presents a challenge to healthcare providers because of its unclear cause and poor response to the medical treatment model. The pathology of CPS is complex, involves many factors, and still is poorly understood by those in the medical community. Some researchers have suggested that chronic pain syndrome might be a learned behavioral response that begins with a noxious stimulus that causes pain. For example, a simple tooth extraction or surgery that causes pain may relate to some behaviors that are rewarded externally or internally. Internal reinforcers are relief from personal factors associated with different emotions, guilt, fear of work, sex, responsibilities. External reinforcers include such factors as attention from family members and friends, socializing with the physician, medications, compensation, and time off from work. Thus, this pain behavior is reinforced, eventually occurring without any noxious stimulus. Chronic pain can seriously affect people's lives in many different areas, such as relationships, work, hobbies, and performing simple daily activities. Emotional symptoms are depressed mood, a reduction in energy level or fatigue, decreased activity level, and decreased libido, along with coping styles related to excessive use of drugs and alcohol to manage the pain. What helps is for people to try to keep areas of their life in balance. In order to cope adequately, everyone needs to realize that pain causes physical and emotional distress. In most situations, chronic pain sufferers can overcome the anxiety and fear that is brought about by chronic pain by learning ways in which to manage these emotions. By concentrating on a balanced approach when handling everyday tasks or duties, chronic pain sufferers can learn to manage the pain constructively. For example, be careful when taking on daily tasks. Doing too much or not enough can result in added stress and increased pain. If people are taking medications, always take the medicine at the same time every day to prevent any unnecessary increase in pain level. When emotions relate to pain, the amount of stress and anxiety that is created varies. Therefore, cognitive behavioral therapy can help the chronic pain sufferer successfully cope and accumulate methods to manage everyday stressors. By learning effective coping strategies, people can find the drive and determination to live happier and more productive lives. Cognitive and psychological symptoms. Chronic pain not only affects the sufferers physically, it can also have pronounced cognitive and emotional effects. Therefore, the psychological ramifications, such as having difficulty processing information, as well as the physical discomfort, can be difficult to manage. With chronic pain, people may be subjected to forgetfulness, difficulties in performing everyday tasks, problems with communicating, and a lowered ability to concentrate. Because of the prevailing pain of the disorder, fibromyalgia provides an excellent example of what kinds of cognitive and emotional difficulties can emerge from this diagnosis. For example, the fibromyalgia patient often suffers from forgetfulness, inability to concentrate, reduced attention span, and the ability to respond with any quickness or adeptness when performing certain daily activities. These kinds of cognitive problems are linked to the anxiety and depression symptoms that are associated with the disorder. Pain certainly can have profound psychological effects on the lives of the sufferers. For example, in the case of fibromyalgia, patients usually experience widespread pain, which is a pain that is heightened by any type of pressure. This condition can give way to such symptoms as tiredness, insomnia, problems with swallowing, and joint stiffness. The researchers Mork, Vazelin, and Nielsen in 2010 investigated whether physical exercise and high body mass index influence an individual's risk of developing fibromyalgia. The study included 15,990 women, none of whom at baseline had fibromyalgia or any other physical impairment. By an 11-year follow-up, the incidence of fibromyalgia had reportedly occurred in 380 women. The authors noted that a weak association existed between exercise level and fibromyalgia risk. However, women who were obese or overweight had a 60% greater risk for developing fibromyalgia than did women of average or normal weight. An individual who is overweight or obese has an increased risk of fibromyalgia, particularly among women who also report low levels of physical exercise. Pain and gender differences. Across many distinct ailments, females report that they endure more pain than men. Nearly all human investigations of sex variations have matched the number of females with the number of men who state they are in discomfort. However, almost all have not studied intensity levels, and numerous studies have not involved sufficient people to be effective in identifying variations between the sexes in pain awareness. One investigation combined data from 11,000 cases from pain rates that were entered into electronic medical records at Stanford Hospital between the years of 2007 and 2010. Patients were directed to rank their pain on a range of 0, no pain, to 10, worst pain. For nearly all illnesses, females described higher pain rates than males and were on average 20% above male accounts. Females with lower back pain consistently recorded higher rates than males and also expressed feeling more pain in the neck and sinuses, which are results not detected in prior investigations. Females may attach different numbers to the level of pain they notice, opposed to males, for some unexplained reason. Previous investigations imply a few factors which may add to the difference in the judgments of pain level, involving psychological factors, hormones, and genetics, which may differ between males and females. Pain systems may function uniquely in females and males, or females may encounter more severe forms of illness than males. Future investigations are required to ascertain the precise reason of pain judgment variations, which would be the first to target for more efficient pain management. Biological markers for pain, such as proteins or genes, would take some of the subjectivities out of evaluating the existence of pain, but the description of these markers is going to be a future challenge. Lastly, here are a few tips on how to learn to live with pain. Emotional stress can be influenced by a number of factors with respect to chronic pain. When beset by stress or anxiety, the chronic pain sufferer needs to consider the degree of pain that is felt on a scale of 1 to 10, sleep patterns, triggers that bring on pain, ways they are coping with the pain, and the amount of psychological and emotional support they are receiving. Look for natural ways to cope with pain. Managing pain-associated anxiety is ideal for keeping pain under control and enhancing the immune system functioning. The chronic pain sufferer can enjoy a better quality of life by using alternative treatments, such as cognitive behavioral therapy, eating healthily, and following a regular regimen of exercise. Therefore, finding natural alternatives to relieve pain is preferred over dependence on medication, which can reduce the sufferer's overall enjoyment of life. Exercise is one of the best ways to reduce pain. Chronic pain can be helped as well by following a healthy, nutritious diet. Exercise produces endorphins, which are mood-elevating hormones that are useful in combating pain. To reduce pain, the endorphins work in conjunction with analgesic-type receptors in the nerve endings, spinal cord, and the brain. Exercise is probably the best way to treat pain because the endorphins that are produced during a workout are usually many times more powerful than analgesic medications and are non-addictive. Chronic pain sufferers can reap the benefits that are provided by endorphins by taking part in daily or regular exercise. The endorphins are proven pain relievers, which can reduce anxiety and the existence of symptoms associated with stress and effectively manage chronic pain. Try to make a few behavioral changes. People need to examine how they're currently feeling to better manage pain. For example, if people feel frustrated or irritated, then it is helpful to recognize the feelings and then examine the behaviors that go along with the emotion: irritability, angry, sad. It is helpful to examine behaviors to assist the need to possibly initiate a change in the emotion and/or behavior. Pain medications. There are two main types of medications that are prescribed for the reduction of pain. Health practitioners recommend people use drugs that fall under the classifications of analgesic or NSAIDs, non-steroidal anti-inflammatory drugs. They may also suggest antidepressant medications in some cases as well. Among analgesics, acetaminophen, sold under the well-known brand of Tylenol, is often used to reduce pain. While analgesics are specifically to relieve pain, NSAIDs are designed to reduce both pain and inflammation. Therefore, NSAIDs are often used to manage arthritis pain because the discomfort is brought on by swelling and inflammation of the joints. The most popular NSAIDs that are sold as non-prescription over-the-counter medications are ibuprofen and aspirin. NSAIDs not only relieve pain and reduce inflammation and swelling, they also thin the blood. Therefore, they have been found to be helpful in low doses in preventing heart attacks. On the other hand, frequent use of NSAIDs can cause stomach upset and/or kidney difficulties. Therefore, patients should inform their doctors what medications they are currently taking to avoid any adverse drug interactions or side effects. Women who are pregnant, asthma sufferers, individuals with kidney or liver problems, people taking medications for high blood pressure, people taking blood thinners, and those individuals who have had ulcer problems in the past should be careful about taking NSAIDs and consult their physician. Various treatment approaches to decrease pain. 1. Herbal medicines. 2. Chiropractic therapy. 3. Physical and occupational therapy. 4. Yoga, massage, trigger point therapies, acupuncture, mindfulness. 5. Cognitive behavioral therapy, EMDR, hypnosis, meditation, and visualization techniques. 6. Pain medication. In conclusion, focusing on the positive. Pain affects not only memory, but how people think and feel about life in general. It is understandable that the more suffering people feel, the more cynical, angry, and negative their outlook on the world becomes. How to learn to live with pain is no easy task. Try to realize that you're not feeling well, and then attempt to discover new ways to self-soothe and comfort. Try to view yourself from a healthy and positive perspective by acknowledging all of your sound, working physical parts. such as, "My left arm feels terrific." This technique, if practiced consistently, works by changing the overall outlook on life. Instead of focusing on the negative, you are now focusing on the positive. Psychological interventions do indeed help manage pain. Consider asking your physician for a referral to a health psychologist to assist in learning new ways to cope and get back into enjoying life's treasures. Humans have consistently attempted to explain why they endure discomfort and the origins of that pain. Even though pain was long ago assumed to be the product of a malevolent god, it is presently perceived as having a neurological cause. Nevertheless, the judgment of pain is not fixed and can be influenced by several factors, including the circumstances surrounding the painful provocation, the visual perception of the provocation, and an individual's personal history of experiencing pain. Contemporary research has collected substantial amounts of evidence that advances the conclusion that pain is not just the physical event, but a biological, psychological, and sociological phenomenon, embracing culture, nerve cell stimulations, the environment surrounding the event, and past personal experiences. This is Dr. Cheryl McDonald of Health Psychology, and thank you for listening to Life with Chronic Pain.